Mr Tunde.
My lady, please may I call Nicola Dickey.
I'd just like to repeat after me.
I do solemnly,
Sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Let's take a seat.
Good afternoon.
Please provide us with your full name.
Nicola Dickey.
Thank you for coming back to provide evidence for this inquiry, and thank you for your witness statement dated the 14th of April 2025. If I can just start with your role during the pandemic, you were the Health and Social Care Chief Officer for the Convention of Scottish Local Authorities from February 2020 until September 2021, is that correct?
That's correct.
And I'm going to refer to the convention as COSLA throughout. What was your responsibility in that role?
So I delivered policy as it related to health and social care. So that included adult social care, mental health policy, National Care Home Contract, all of the stuff as it related to health and social care for the organisation on behalf of our 32 member councils.
And in October 2021, you became Director of People Policy in COSLA. What was your responsibility in respect of the adult social care sector in that role?
So the chief officer role that I had, someone else took on that role, and then they reported to me as the director alongside chief officer who was dealing with children and young people and COSLA Strategic Migration Partnership, which is asylum and migration.
I'm terribly sorry to interrupt. Can you slow down?
Yes,
Otherwise, I'm going to have a stenographer
I will try my very best.
complaining. Thank you.
What is your role currently?
I'm the director of People Policy now.
Thank you. I'm going to ask you some brief questions about COSLA. My understanding is that it's a councillor-led, cross-party organisation with all 32 unitary authorities as members. Is that correct?
That's correct.
It also has a health and social care board, which leads on all aspects of policy development and political lobbying in relation to health and, adult social care for COSLA. Is that right?
Correct.
What was the role of COSLA in the context of the adult social care sector during the pandemic?
So during the pandemic, we provided leadership from our sector. As an organisation, we fed into national discussions. We provided political representation at all of the various meetings that were set up to guide us through the period of the pandemic. We were also responsible for agreeing and delivering the sustainability payments for the adult social care sector.
In terms of the adult social care sector in Scotland, it's my understanding that local authorities have statutory responsibility to provide adult social care services, and local authorities and NHS boards are integrated or work together in order to achieve that. Is that correct?
That's correct.
How is this done? Through what organisations?
So local authorities will agree what services they wish to delegate to their IGB, which then governs those services. So all of the local authorities in Scotland have delegated in some way their adult social care. So we've got 31 health and social care partnerships. The services are delegated, and therefore it's up to the health and social care partnerships to agree and plan for the types of services that should be provided. That includes in health services, but it also importantly includes adult social care services, and in some instances, children's services and justice.
And you mentioned IJB. Could you just tell us the full?
So integrated joint boards are the governance mechanism. So that's the decision-making body, and the health and social care partnership is, if you like, the delivery arm. So that's where you've got your paid officials who will take forward the work.
Were there any advantages or disadvantages to this model during the pandemic?
So I think the advantages were that we were already used to working in partnership to deliver services at a local level across Scotland. It meant that there was a degree of integration already there in kind of peacetime, if you were. And many of our services and service users were used to getting services from both health services and social care services as we went into the pandemic.
So in Scotland, would you say that, for example, the NHS, the health side, had a good understanding of the adult social care sector because of these integrated models?
I think the NHS had a good understanding of community services as they are provided in Scotland. I think the acute services that sit out with our community provision were perhaps not as integrated as they could have been, just by nature of the very fact that they're taking place inside hospitals as opposed to community provision that's provided across communities in Scotland.
I'm going to ask you some questions about the pre-pandemic capacity of the adult social care sector. And if I could pull up INQ 000147362, page 5. Now, this is the Adult Social Care Winter Preparedness Plan, which was dated the 6th of November 2020, but it kind of gives an overview of the adult social care sector in Scotland. Around 245,000 people receive social care and support in Scotland. Around 60,000 people in Scotland are receiving home care at any one point. The majority, 77% of people requiring social care services or support are aged 65 or over. People residing in care homes tended to be older, with around 90% of residents aged 65 and over, and 1 in 2 aged 85 plus. However, it acknowledges that not everybody receiving adult social care is older. There are younger adults as well. And if you just go down, thank you, and have a look at the numbers employed. As at December 2019, there were 206,400 people employed in the social service sector. There is a COSLA survey that was undertaken for this inquiry, and in it some of the local authorities answered the questions on preparedness. And if I can pull that up, please, it's INQ 000587789, slide 6. Sorry, slide 5. As you can see, on preparedness of the 29 local authorities which responded to this question, 52% said that the preparedness of the sector was not very good, and 3% said not good at all. So that's a total of 55%. And capacity of the care sector, 41% said not very good. Ability to increase capacity, 55% said not very good. However, when it comes to the resilience of the care sector, 72% of the local authorities that answered said it was very good or fairly good. And if we can turn to slide 6, of the 14 local authorities that reported that capacity or resilience were not good, many of the reasons why I listed there, all 14 mentioned workforce recruitment difficulties, rising demand for adult social care services, funding pressures, etc., going down on a sliding scale in terms of the numbers. You'd stated in your witness statement at paragraph 2.25 that issues relating to the sustainability of the care sector in Scotland, specifically in relation to capacity, were largely as a result of funding and workforce issues, which COSLA had raised consistently with the Scottish Government. How did these capacity, funding, workforce issues affect the preparedness of the social care sector in Scotland when the COVID-19 pandemic hit?
So the capacity issues meant that already most areas of Scotland were only providing support through adult social care to those with high or severe support needs. Those on low to medium support needs were probably not featuring in terms of access to support.
And in terms of pre-pandemic planning, who or which organisation was responsible for pre-pandemic planning?
So health and social care partnerships were responsible for the day-to-day planning. If we got into a situation where we needed to step in to a resilience situation, then local authorities and health boards would step in as Category 1 responders at that point. But the day-to-day planning and therefore annual winter planning was the auspices of the Health and Social Care Partnerships.
And were there any requirements for care providers themselves to have plans in respect of emergencies?
So there would be contractual obligations on recipients of the National Care Home contract. So there would be expectations in terms of, access to PPE should there be an infection or an outbreak, etc. So there were that type of expectation on individual care homes to make sure that they had access to that, and then they would all be feeding up into the overall planning that was being done through the local area plans.
And then to zoom out and look at it on a more macro level, in terms of the Scottish Government, etc., more national planning, I understand that there was the Scottish Government Resilience Room, and under it the National Incident Management Group and the National Contingency Planning Group, which in your statement you state both groups were established prior to the relevant period and were constituted in such a way as to ensure there was a coordinated public sector response to emergency or critical incident situations in Scotland. Were either of those organisations responsible for pre-pandemic planning on a national level for the adult social care sector?
So the SCORE arrangements are normally stood up in response to an emergency, so they're not standing arrangements that sit all of the time. So if we perhaps had a cluster of outbreaks of some infection, we might have been in a situation where SCORE would have been stood up. The National Contingency Planning Group is a group that COSLA would bring together in normal times. If, for example, we had a large care home that was faced with closure and a lot of residents that we needed to move out, or a string of care homes across Scotland that were needing coordinated arrangements to make sure that residents were being moved into alternative provision. So the National Contingency Planning Group was one that we would bring together as and when required. So whilst it was a standing group, it didn't meet all of the time. We started off with a National Contingency Planning Group, but as the scale and it was clear just how much of a difference COVID-19 was going to make, that was where we transitioned from almost kind of one issue National Contingency Planning Group or one site into the arrangements that we had that took us through the period of the pandemic.
Is there any national pre-pandemic planning sort of organisation that exists now or before the pandemic that COSLA was involved in?
So what we do have is each of the health and social care partnerships will provide an annual plan where they will plan for peaks and troughs throughout the year. Given that winter is always a particularly pressurised time in the health and social care partnerships, those plans are written at a local level, and then they are fed into colleagues in government, and colleagues in government will check those plans and make sure that they are sitting in and against any national planning that they have done for the NHS or the social care system. So I suppose it's a kind of averaging up, if you like, in terms of the 31 plans come in, colleagues in government will look at them, and then they'll provide feedback to a particular area to say that doesn't look strong enough in terms of planning, or can we support you with that type of thing. So I don't know that it's pandemic planning in that respect, in terms of it's the day-to-day way in which we deliver services in Scotland.
Do you think, let's say there is a future pandemic that is coming into the fore in the horizon, do you think the current setup for pre-pandemic planning, which sounds like it's more on the local level and then fed up nationally, do you think that is an adequate way for Scotland to prepare the adult social care sector for future pandemics?
I think given the differences in areas across Scotland, you do need to start local. I think there are a number of things that it would be useful to almost have sitting to the side that you would consider as things that could be taken over nationally very quickly in the event of a pandemic. And I'm sure we're going to come on and talk about PPE and provider sustainability payments, who is classified as a key worker, for example. These are things that at a local level it would be very difficult during a pandemic or in the run-up to a pandemic for an individual local level to do. So I think the local planning and the pushing it up the way is right, but it feels to me that we need a suite of things that we can kind of regularly go back and review in terms of that. Nationally, yeah.
Thank you. I'm going to ask you some questions now about your liaison with the Scottish Government and other stakeholders during the pandemic. We briefly touched upon the National Contingency Planning Group a moment ago. There were some other groups or subgroups that COSLA was involved in, one of which was the Workforce Issues Group, which I understand was constituted in May 2020. Is that correct?
Yes.
And what was the purpose of the group?
So that group's purpose was an area where we could consider workforce issues as they applied to the local government workforce, so not specific to just adult social care. So it was everyone who worked for local government, and that was across, as you can imagine, waste operatives, teachers, adult social care. So that was where we discussed all of the workforce issues as they were arising from the local government workforce. Obviously, there are some staff in Scotland who provide adult social care that are employed by local government, but we had the separate forums where we were having conversations about the adult social care workforce that didn't work in local government. There were times when some of the issues were the same, and there were times when some of the issues were very different. For example, access to sick pay between local government adult social care staff and those who don't work in local government.
Okay, so the Workforce Issues Group, as you just said, was in respect of people who are employed by the local government. So would that group have dealt with adult social care staff that were not directly employed by local government, that were employed by private providers?
No, that stuff would have come up through the pandemic response, because that was where we had representatives from the third and independent sectors.
So that's the pandemic response in adult social care group, which was set up in September 2020. Is that right?
Yeah, and it was a follow-on to some of the work that was being done through the Care Home Rapid Action Group and the regular meetings that we had stood up.
So was it that group, that pandemic response in adult social care group, that just started to deal with the specific issues that members of staff in the adult social care sector were facing?
So I think the pandemic response in adult social care was when it became formally constituted. There were regular meetings before that. They were titled Gold sometimes, they were Silver Commands other times, but there was regular dialogue, and I think you can see that from some of the exhibits that we've provided. There were regular dialogue with those providing adult social care.
Prior to September
Absolutely.
2020. Thank
Yes.
you. And you mentioned the Care Home Rapid Action Group that was established in April 2020 to address the urgent needs and challenges faced by care homes during the pandemic. Is that right?
Yes.
How effective was that group in your view?
So I think the group was effective in that it looked at issues of infection and prevention control. I think that the fact that the group was set up around about infection and prevention control meant that we were bringing, if you like, the existing doctorate that had come from how things worked in our hospitals. And I think we took a while to get our heads round about the fact that care homes are not hospitals. They're not, the physical location is not like a hospital, and indeed the way they are actually used by people who are living in care homes. So we were relying very much on the infection prevention control specialists to bring that type of expertise, but we were working hard from a COSLA perspective to make sure that we were bringing in the expertise of our chief social work officers, of our own health and social care chief officers who were used to providing services in these areas. So we were trying to kind of match up the health elements with the social care elements to make sure that what was there worked for the infection and prevention control measures that were required, but also that didn't turn care homes into hospitals.
So you mentioned time needed to understand that care homes weren't like hospitals, and therefore IPC measures needed to be different for them. Do you have any examples of the differences and why IPC measures needed to be different for care homes?
So I suppose we've referenced one example in the statement around about Christmas decorations, and recognising that these are people's homes, and the concept of saying to someone they can't put up a Christmas decoration is probably not going to land that well. I think another example is, you know, in many cases, residents in care homes are free to move around the care home. So when you were starting to say, you know, infection prevention measures mean you've got to be kind of confined to the one area, we had to make sure, I suppose it's different in a hospital because to an extent doctors and nurses and other professionals are controlling the flow of movement, but in modern care homes, people don't necessarily have their movements restricted. So there were a lot of time was having to be spent to make sure that what was coming through in the guidance, that absolutely the infection prevention control guidance was there, but it needed to come with a degree of additional explanation, because people were going to have to explain to residents and their families why, you know, a relative potentially was going to be kept in their own room when they had been used to moving up, for example, into, you know, communal day rooms where they could sit and be with other residents.
And before I move on from this point, we've mentioned staff. We've also mentioned care homes in respect of groups that were set up. What about domiciliary care?
So both Scottish Care and CCPS, who we were engaging with, represented those who were providing home care, not just care homes, although the mix across the two organisations. And we also had our own workforce who were providing domiciliary care. So there was still the same ability to have that conversation with those representing the workforce that were providing domiciliary care.
Was that happening early in the pandemic, or do you think it took some time before?
So I think it was happening early in the pandemic to an extent. I think the issues that we were starting to see in care homes meant that there was a lot of focus went on to that. But I can remember conversations early in the pandemic about what was the guidance for domiciliary staff when they were, as we were talking about, donning and doffing their PPE, and how did you do that, you know, potentially in a rural location in the dark and in the wet. So there were certainly conversations going on at that point, again, to make sure that people could be clear what was the guidance that they were being asked to follow, and importantly, how could they implement that.
I'm going to move on to discuss isolation. When it comes to hospital discharge, I will leave those questions for the core participants once I've finished. But I do have a question in respect of designated settings in England and Wales. In England, and also the step-down facilities in Wales. In England, the UK government created designated settings, which were specific care homes that had isolation facilities to house COVID-19 positive people. And in Wales, they implemented a step-down and step-up policy where people who were COVID-19 positive, still displaying symptoms, and all still within the 14-day isolation period, would be transferred to an NHS facility to recover before then being returned to, let's say, their care home or their own home. Was a similar policy adopted in Scotland?
So I can't recall COSLA being engaged in conversations around about anything that would have worked in that way at a Scotland level, and it's certainly not referenced in any of the submissions that have come in from the member authorities.
Do you think something like that would have been useful or needed in Scotland?
I think it might have worked in our areas that there was a lot of access to care homes. I suspect that might have been more problematic in our remote and rural areas where you're already travelling large distances potentially to access a care home. And we certainly had quite a bit of upset from residents and indeed relatives where they were not potentially getting their first choice, as it were, for care homes, because we had care homes that were close to admissions. So it might have worked in our more highly populated areas where you had 3 or 4 care homes in a maybe 5-mile radius. I'm not so sure it would have worked in big remote areas of Scotland where, you know, the distance between care homes and therefore the distance that relatives might have been asked to be moved to visit would maybe be miles. But I would need to understand exactly how they worked in England to give a more definitive answer on that. But the geography would certainly have been a consideration, I suspect, for us.
Speaking of visiting, I'm not going to ask you any questions about visiting restrictions because, again, I'm going to leave that to the other core participants. But I am going to ask you a question about Anne's Law. At paragraph 3.9 of your witness statement, you mentioned the distress and upset caused by restrictions placed on care home visiting. You also state that the Care Reform Scotland Bill had been introduced in Scottish Parliament, which introduces Anne's Law, which would give visitation rights in the event of another such pandemic, and that COSLA fully supports that legislation. To help the UK COVID inquiry understand Anne's Law, could you please inform us what stage the piece of legislation or proposed legislation is at in Scotland?
So as far as I'm aware, the concept of Anne's Law is in the amended bill that the Scottish Parliament still currently has on its statute books, which should hopefully be seeing its passage before the end of this parliamentary term in Scotland.
In respect of Anne's Law, my understanding is that it would provide rights for a visitor to see a loved one in a care home. May I just confirm from you whether that would be during a pandemic as well?
As far as I'm aware, it would be in only the most extreme cases that you wouldn't be permitted to have a relative access you in a care home. So I would assume that would mean for the period of any future pandemic, and indeed where we've got outbreaks of infection prevention control over the winter period.
Thank you. I'm going to move on and ask some questions about the management of the pandemic generally, and in particular the enhanced professional, clinical and care oversight of care homes. Now, as previously stated, in Scotland, the delivery of adult social care is more integrated than some of the other nations in the UK. With this enhanced professional, clinical and care oversight of care homes, could you please just explain to us what that was?
So that entailed clinicians and more often than not nurses taking a more hands-on approach, as it were, to how things were being run in care homes. So from a COSLA perspective, we obviously didn't have the expertise to go in and do that, but we were in a situation where we were able to make sure that the balance of that clinical oversight, we were still feeding through what were potentially implementation issues with whatever might be being suggested, because we were picking that up from our member councils and indeed professional associations that are associated with adult social care.
Mm-hmm. So my understanding is that it included multidisciplinary teams comprising of the NHS Director of Public Health, an executive nurse lead, medical director, chief social work officer and others, who would effectively assist in the oversight of care homes. I would presume also providing advice in respect of like IPC measures and things like that. And sorry, that was a nod.
That's
yes.
my understanding, yes.
Thank you. My understanding is that they also would undertake visits to the care homes if, for example, patients had tested positive and
yes.
things like that. Would you say that this was beneficial during the pandemic for care homes?
I think it was beneficial for care homes during the pandemic, even if that was just to have a bit of reassurance that someone else was coming in and was kind of looking at what you were doing and checking you were complying.
Would you recommend the same system in a future pandemic?
Yes.
I'm going to ask some questions on data. What were the issues regarding data in Scotland at the start of the pandemic for the adult social care sector?
So as I've said in the witness statement, we had no national oversight of what occupancy rates were like, what workforce statistics were like. So local systems, so health and social care partnerships and those tasked with delivering it at a local level had that oversight. They could tell you where they had vacancies, where they potentially had outbreaks of other issues and indeed where they had any pinch points in the workforce, but we didn't have access to that at a national level, which goes back to the point I was making earlier about you have to deliver it, design it and deliver it locally, but you need the ability to push things up if we need more support than what the local system can provide.
And from your statement, I've noted two potential data gathering tools or mechanisms. One is the safety huddle tool, and the other is the data dashboard. Am I right in understanding that they're both two separate systems, as it were?
Yes.
And in respect of the safety huddle tool, my understanding was that this was in force from the 14th of August 2020, is that right?
Yes.
Do you know when the data dashboard came into force? Was that earlier or after?
So the data dashboard was somewhat iterative in terms of as we were going through. So the data dashboard was a kind of melting pot, if you like, of as we started to see, testing coming on board, we were adding that information into it. So you got to the point at a national level where you could look and see, how many tests had been done, how many had been undertaken, etc., etc. But it kind of started off with a few things on the dashboard, and as we went forward and we got more information from the safety huddle tool, we kind of grossed that up.
Have the improvements in collecting national data continued to date?
Yes.
If there was a future pandemic, do you think that the data currently collected would be sufficient for, on a national level, to support care homes and home care?
Yes, I would, and we use it for winter planning purposes as we move forward.
Do those mechanisms include data in respect of unpaid carers?
No.
No. Is that data being collected by local authorities or national level?
So one of the kind of lessons learned or recommendations, I think, is about data sharing, and unpaid carers is a really good example. So there would be 3 or 4 different systems in local government where somebody might be classified as an unpaid carer because of things they're accessing. That may well be on their GP record, that may well be somewhere else, but it's quite difficult to get a collective list of our unpaid carers. So I think that's an area where we need to work to join up the various bits of information that would be useful.
Thank you. If I could just pull up a statement from the care inspector on screen. It's INQ 000 475 130. And we're looking at paragraph 92. In this paragraph, the care inspectorate state that the new safety huddle tool, which captured daily data for care homes, existed. But then if you go to the second page, the first sentence, it says, however, I understand we did raise strong concerns from the outset that the safety huddle tool, involved duplication of data provision, which would impact on care service providers who would experience it as a duplication of effort on their part. Did you hear similar concerns regarding data collection from care providers?
I don't recall, but to be honest, there was a lot going on. I wonder if the reason why we went for the safety huddle tool is that it was a continual record as opposed to a snapshot in time. But I don't recollect the exact issue that's been raised there.
Do you think perhaps in the context of considering a future pandemic, trying to find ways in which the data can be collected which aren't too much of a burden for care providers is something that should be looked at in Scotland?
Yes.
Thank you. I'm going to move on to workforce issues, and if I can ask for the COSLA survey to come back up on screen. That's INQ 000 587789, slide 7. This is a bit similar to the previous that we looked at, but it's about the care sector during the pandemic. As you can see, of the 29 local authorities who responded to this question of capacity, 31% said that it was not very good, and 3% said it was not good at all. And on the ability of the care sector to increase capacity during the pandemic, 45% of local authorities said not very good, and 7% said not good at all. And if we can turn to slide 8 quickly, please. Again, it's similar issues that were raised previously in terms of pre-pandemic preparedness, workforce recruitment issues, retention difficulties, etc. Since the pandemic, Has capacity in the care sector, adult social care sector, improved in Scotland?
I would say it's probably about the same.
About the same.
I think we still have workforce challenges in terms of recruiting and retaining staff in the social care system.
And in terms of attempts to increase capacity during the pandemic, the National Recruitment Portal was established in April 2020, is that right?
Yes.
How useful was it?
I think it was useful to an extent. I think it allowed us to bring people who had perhaps not long left the adult social care system back. We did something similar across the NHS workforce, of course. I don't know that it necessarily got us any new recruits who maybe hadn't considered social care as a career up until that point. What I would say is COSLA as an organisation also runs My Job Scotland, which is where we put all of the vacancies for local government, and we've extended that, so we now put vacancies for independent and third sector providers for adult social care on that website, so there was an opportunity there. The other thing I would say about it is that we maybe didn't get hundreds and hundreds of applications, but there was a really strong signal that colleagues in a NHS board through NES were willing to work with the adult social care sector to try and support us with our recruitment challenges. So I think that shows and demonstrates the collaboration and partnership that we've alluded to throughout the statement.
Mm-hmm. And just on that, if you could just give us a little bit more information, how did the sort of NHS assist with this increasing of capacity?
So I think that Cabinet Secretary asking an NHS board in the time of a pandemic to help us deliver on recruitment challenges in social care was a pretty strong signal that it wasn't over the social care system of on its own to fix the recruitment challenges. So I think it was a pretty strong. They could have been off doing something else, I'm sure, but there was a recognition there that the social care workforce needed to be augmented in the same way that the NHS did.
Thank you. I'm going to ask you some questions in respect of PPE, personal protective equipment. And if I could just pull up the Scottish Trade Unions Congress statement, INQ 000569884 and paragraph 75. This is a quote, I believe, from GMB Union, where it states that there was a shortage of PPE in private care homes and there wasn't enough PPE for everybody who was providing direct care. Generally speaking, there was an overall shortage of PPE in the country. So initially the PPE was so scarce that it was being directed towards the NHS, where people who were contracting COVID-19 were being taken. People working in care homes or in community care therefore weren't getting access to PPE, or the equipment that was coming in wasn't proper equipment that it should have been. They also go on to talk about concerns about the quality of PPE, stating that they felt that our members, overwhelmingly low-paid, working-class women, were being provided with the cheapest possible masks or really low-quality plastic gowns. Was COSLA aware of the concerns regarding access to PPE at the beginning of the pandemic?
So I think we provided the inquiry with our risks and issues log, and PPE was raised very early on in the pandemic. So COSLA were aware from both conversations on our own workforce, those that were employed by local government, and indeed those that were commissioned to provide services.
And I understand from your statement that there were near daily calls with trade unions and COSLA, and PPE was also raised in some of those calls. Now, in respect of PPE provision, what was the role of local authorities in Scotland in providing PPE, distributing it to the adult social care sector?
Before the pandemic or during the pandemic?
During the pandemic.
During the pandemic. So, as I said earlier on, the National Care Home Contract provides that providers supply their own PPE for their day-to-day running. It became clear that the scale of the PPE that was required was not going to be useful for individual providers to be trying to source that. I'm sure you've heard elsewhere about the market there's no point everybody bidding in the same market. So using our existing procurement systems in Scotland through both the National Health Service and indeed Scotland Excel, who procure on behalf of local government. We were able to source PPE, and then local government signed up to a memo of understanding with Scottish Government and colleagues elsewhere, and we then provided hubs for access to PPE, so individual care homes and domiciliary care could come forward and draw down some of that PPE. We also opened access to unpaid carers, and they were either coming in individually through local government routes, or they were coming in through carer centres to access PPE.
And that memorandum of understanding, the MOU, commenced on the 27th of April 2020, is that right?
Yep.
I understand there were 50 PPE hubs that were put
Yes.
up into existence, and they were managed and operated by the 31 health and social care partnerships.
Yes.
How successful would you say the distribution of PPE was through the PPE hubs?
I think the distribution was successful. I think there were always pockets of best practice that could have been better. I suspect the fact that you're dealing with 1,200 disparate social care providers across 50 hubs in a time of a pandemic meant that there were some confused messages, but for the most part, we heard a lot less in terms of access to PPE once the hubs were up and running. And I suppose those weekly calls that we were having with social care providers was an opportunity for people to say, you know, it's working really well in that area, but there's something not quite right in that area. And that would allow us as a membership organisation to reach out to that individual local authority and say, is there something we can help you with? Is there something that's you're confused about or whatever?
If we could pull up the COSLA survey again, INQ 000587789, slide 12, please. This is about accessibility of PPE in the first 6 months of the pandemic. Overall, in the first 6 months, how easy or difficult was it for care providers within your local authority area in finding access to PPE? Of the 29 local authorities that responded, 45% said providers found it either very or fairly difficult in the first 6 months of the pandemic, and 38% said they found it very or fairly easy. If we could pull up the Local Government Association survey, that is INQ 000400522, page 45, table 25. As you can see here, the local authority counterparts in England and in Wales have also answered that question. 87% of local authorities in England said that they found it very difficult or fairly difficult to obtain PPE in the first 6 months of the pandemic. And in Wales, 55% said that they found it very difficult or fairly difficult. Both of which are higher than the 45% of providers that was mentioned by the local authorities in Scotland. Do you think there was anything in particular that was particularly going well in terms of PPE distribution?
I suspect the fact that we utilised our existing procurement routes, so we already had contracts that were up and running, and we didn't have to step outside those. So Scotland Excel were always had and always continued to be able to procure on behalf of all 32, and similarly our NHS procurement arm were in a similar situation. So I suspect that in itself meant that because we had those tried and tested routes, it was a bit simpler. But again, I don't know why our colleagues in LGA and Welsh LGA, I don't necessarily know their systems as well as I know the Scottish system.
I'm going to move on to ask questions about testing for COVID-19. Some other local authorities in other nations were involved in some way in respect of providing tests to either staff and or residents during the pandemic. What role did local authorities in Scotland play in respect of testing?
So we had no formal role in the testing regime in terms of actually performing the tests. Where local government did support our colleagues in the NHS was in access to infrastructure. So knowing where was the right place to put a local testing system, knowing what the transport links were like, accessing some of our buildings that were closed, etc., etc. And then the other support that we provided in response to testing was support for shielding individuals and indeed access to support for people who were having to isolate and needed access to some income.
And my understanding is that when it came to lateral flow tests,
Yep.
those were made available through the PPE hubs, is that right?
Yes, and importantly that included for unpaid carers.
For unpaid carers as well. Do you remember when that started?
As far as I'm aware, the lateral flow tests were available from the get-go, as it were, in terms of once we had the hubs up and running, they were there as soon as we had them in any scale.
I won't take us to the surveys again, but I will read the responses. In respect of COSLA's survey, of the 29 local authorities that responded to the question in respect of access and testing for care providers in the first 6 months of the pandemic, 45% found it very or fairly difficult. In respect of England, local authorities in England, 84% of local authorities said that care providers found it very or fairly difficult to access testing in the first 6 months, and in Wales, 73%. Obviously, you do not work in the other nations, so I'm not going to be asking you what went badly there versus what went well in Scotland. However, I would just like to know, from your perspective, what went well in respect of testing in Scotland? Were there anything that needed to have been improved going forward, or do you think it went swimmingly?
I think it went as well as it could have done, given that we were waiting on tests being developed and other bits and pieces. But I think the integrated nature of the system in Scotland meant that we never had a situation where we were potentially having to prioritise one part of the system against the other, because there was a recognition that, you know, the integrated system means that we need to know across all of the workforce where we needed access to testing. And I think the fact that we did put that into the PPE hubs meant that there was a tried and tested method of getting that out.
Thank you. I'm going to move on to ask you some questions about funding, and I'm actually going to start with the provider sustainability payments. Similarly to the other nations, there were concerns in Scotland about the sustainability of social care providers, which existed during the pandemic. And this was due to the impact of additional costs because of the pandemic, such as staffing, sickness, PPE, and also a decline in care home occupancy. Is that right?
Yes.
And the Scottish Government introduced provider sustainability payments to cover the additional costs in May 2020. Is that right?
Yes.
My understanding is that the provider sustainability payments were distributed by local authorities. Is that right?
That's correct, yeah.
If I could pull up the Scottish Care Witness Statement, that's INQ 000500530, paragraphs 113 to 114. Here they talk about issues in respect of provider sustainability payments. And they state that there were inconsistencies in the approach being taken to applications for under-occupancy and sustainability payments by local authorities. Local authorities did not have sufficient resources to process the applications, and at times did not explain why applications were refused or partially granted. Scottish Care also say that they liaised with COSLA to highlight the pressures that the sector was under and the challenges that applicants were having when attempting to access sustainability funds. And if we could stick on the statement but go to page 33, paragraph 125 and 126. They also state that social care providers had to apply retroactively for sustainability payments and accordingly had to incur increased costs of providing services without any certainty as to whether such costs would be reimbursed. They also mentioned substantial delays between applications being submitted, being granted, and payments being received, which compounded this uncertainty. Now, in respect of the first point that was mentioned, which was inconsistencies in approach being undertaken to applications for under-occupancy and sustainability payments by local authorities, Was COSLA aware of those issues at the time?
Yes.
What, if anything, was undertaken to try and make things easier or to try and alleviate those inconsistencies?
So what we did was we looked to see if there was a fundamental issue with the process. So was it something that was wrong in the guidance or something that was unclear in the guidance? We made that as clear as we possibly could and made sure that that was then reissued to individual local authorities. We then worked with Scottish Care, I think, twice weekly if there were particular issues in a particular area. That could be to do with the fact that there was a lot of staff who were off sick with COVID themselves in a particular team. It could be to do with the fact that there was perhaps people were approaching the way in which they were looking through applications as if we were in non-COVID times. And, you know, at the end of the day, our finance officers always have to be able to prove good use of public money. But I suppose we were working with individuals. So we were looking at, is there a problem across the piece? Is there a problem with individual area? Taking it right down to, is there something we can do with individual teams? What I would say is that in many cases, the teams that were processing the grants for social care providers were the same teams that were then being asked to issue payments for other sectors that had potentially come through. So there was definitely an issue around about capacity and the ability to, deliver for different sectors, particularly in our smaller local authorities.
And do you think that those issues were improved on during the pandemic?
I think we got better as we were going, but again, we spent a lot of time trying to get to the bottom of, was it relationships in a particular area that were causing issues? Was it the way the applications were coming in? Was it the way the applications were being assessed? So I would love to say we fixed it in the first week and it was once and done, but that was not how things played out. As pressures came back in a fresh winter period, you would potentially have to reach out to individual areas and say, can we help? Is there something with the process that you're not sure about?
And if there was a future pandemic, would you state that that kind of funding should remain being funneled through local authorities, or do you think it should be done in a more sort of national level down?
I think it's right that local authorities will understand the providers in their area, and there's an element of, if you try to do it nationally, it would have to be checked by the local system anyway, and colleagues in government didn't have the capacity to deliver payments directly at that point. So it's not unusual for my organisation to say that things should be done local by default and national by agreement. I didn't see that it would have been any better a process had it been done at a national level, because there would still have been the need to check with the local system about occupancy rates, etc.
And similarly, there was an enhanced statutory sick pay scheme, or the Social Care Staff Support Fund, which was introduced because of concerns about care staff having to self-isolate because they'd only be entitled to statutory sick pay. Those are also funneled through local authorities in a similar way. I'm not going to pull it up on screen, but Scottish Care also mentioned that there were long delays in payments being reimbursed. Do you think that those payments should also remain funneled through local authorities, or do you think they should go directly to staff during a future pandemic to ensure that they get their statutory sick pay? Enhanced sick pay, should I say?
I suspect we would build in a different type of delay if we were moving halfway through to a completely new organisation potentially making a payment to staff. We had all of the bank details, we'd done all of the due diligence, we knew who these care providers were. I think if we could have got the capacity up and running quickly, we wouldn't have seen some of the delays that we saw.
Thank you. I've got one question in respect of changes to the regulatory inspection regime. I'm not going to pull the COSLA survey up again, but 38% of local authorities felt that the suspension of inspections of care homes had a negative impact on safeguarding. What, if anything, did local authorities do to mitigate this?
So I think we had our chief social work officers who were meeting regularly to think about and to discuss what were the areas that were potentially being missed with the fact that we had stood down those visits. And I think if you take the enhanced
clinical governance for care homes. There was a bit of a safeguard in there that other teams were going in that were multidisciplinary. But I think as we move forward, it's one of the things that we should be agreeing in extremis. If we get to a situation where we do that as a minimum, what are we doing over here to make sure that those safeguards were there?
Thank you. And my last area to ask you questions on is in respect of easements. And these were basically Section 16 and 17 of the Coronavirus Act allowed for local authorities to dispense with particular social care assessment duties covering social care for adults, children and support for carers. This was, I understand it, removed on the 30th of November 2020 in Scotland. Is that right?
Yes.
My understanding is that COSLA and Solace were consulted on developing a survey for local authorities to complete on a monthly basis regarding the use of easements. Yes. But you state that the results were collected by the Scottish Government. As such, you were unaware of how many local authorities enacted easements during the pandemic. Do you think COSLA could have had a greater role in respect of easements?
So I think from memory, we probably thought about a third had, but in many respects, for some, that was for a 2-week period or something like that. So I think the fact that Scottish Government were collecting the data didn't mean that we were absolutely unaware of what was happening. But obviously, we're not an improvement organisation; we're a membership organisation, so we don't perform that function.
If I can pull up my final document on screen, please. It's the Inclusion Scotland Witness Statement. That's INQ 0005200202, paragraphs 85 and 86, in which Inclusion Scotland state the emergency legislation allowed local authorities to relax certain duties, but the duty to provide support still applied under Section 12 of the Social Work Scotland Act. Despite this, Glasgow Disability Alliance found that approximately 2,000 disabled people in Glasgow had their care reduced or completely withdrawn from March 2020 onwards, and many were forced to rely on family members or neighbours or go without care. On paragraph 86, they state the easements which allowed care assessments to be put on hold had an immediate impact on care users, as well as raising questions about whether support would be available in the longer time, with social workers in Scotland reporting that some of their service users were left in limbo. What are your views on the reduction of care and also the pausing of assessments during the pandemic?
So I think the statement there from Inclusion Scotland talks to some of the survey results that you've gone over. We did have difficulties in accessing workforce. I think it's difficult to understand of the 2,000 people who had their care reduced, what were their support needs? Were they in the low and the medium category? We moved to a system using the easements or where we were looking at people who had high support or extremely high support needs. It's difficult to know, but I think the pausing of assessments was something that we were really keen to limit the amount of time that we did that, least not because we had people who, because of COVID, their support needs had gone up, but we also had people on the other side who they potentially didn't want access to the social care that they were getting before, and they wanted to have their changes there. So we did try and narrow the amount of time that the assessments were put on hold. And then I think I remember in 2021, we did a kind of go through in terms of how many assessments needed to be redone.
My final question, if there was a future pandemic, do you think that easements should be enacted in order to allow local authorities to reduce some of their services?
I think it would be an option nearer the time that we would need to think about. And I say that because we're going to come on to lessons learned, I hope, because I think the fact that if you don't have your social care system running so hot, I don't know that you would be in a situation where you would need easements. I think the problem is that the system's been running too hot, as you can see from the local authority surveys. So when the easements came in, I suspect there were not a lot of local authorities put easements in because they were already providing support to the people who were in the most need. There probably wasn't any higher you could go.
And just to clarify, when you say so hot, what do you mean by that?
So we were already in a situation in Scotland where most local areas were only providing support through adult social care to those who were in desperate need, if you like, or, you know, at the higher end of the needs threshold.
Pre-pandemic.
Pre-pandemic. So when the easements come in, if you're only providing those who are at the most extreme, I'm not sure that easements make that any different if people are already accessing it at that level.
My lady, those are my questions.
Thank you very much. Mr Weatherby, who's just there.
Thank you, my lady. Good afternoon. I ask just a few questions on behalf of the COVID-bereaved Families for Justice UK. Two topics, hospital discharges to care homes or care settings without testing and visitation. So hospital discharges first. At paragraph 310 of your statement, in respect of hospital discharge, is you say, and I quote, "This is a matter that will have come up at the weekly meetings between the COSLA spokesperson and the Cabinet Secretary for Health and Sport, given the concerns connected with this," unquote. Can you help us what the nature of those concerns was?
Sorry, was that in terms of visiting restrictions or?
No, in terms of the hospital discharges into social care settings without testing.
So I think, as we've alluded to elsewhere in our statement, and indeed if you look at some of the minutes from those earlier meetings, there were two concerns. One was there wasn't access to testing, so the actual physical capacity to test wasn't there. And the other would be if we were in a situation where people weren't being tested, were we clear that the infection prevention control measures that we've discussed were such that we could prevent it?
Right. Were these concerns that COSLA itself had and was raising, or were they the concerns of others that you were aware of and put forward?
So we were gathering feedback from our member authorities, be that from paid officials in those local authorities or indeed from our own elected members. So there's 1,200, just over 1,200 elected members in Scotland who were obviously getting feedback from their constituents. Yeah. But as well, we were also getting information from social care providers through the weekly meetings.
And so far as you're concerned, were the concerns that you raised with the Scottish Government or the Cabinet Secretary for Health and Sport, were they acted upon? And if so, to what effect?
So I think the fact that you can see that we set up the care home action group and we had specifically on infection prevention control, I think as we've alluded to in terms of why did local authorities in Scotland have a difference in access to testing that we saw elsewhere in the UK, that suggests to me that the social care provision was understood by the Cabinet Secretary and we acted upon those concerns.
Yes, okay. I think you may have answered my next question, but just for clarity, I'll ask you again. Were members of COSLA raising concerns about the hospital discharges without routine testing and also the adequacy of IPC measures at this time?
Very early in the pandemic, I suspect a lot of it was potentially coming through word of mouth, as it were, because not necessarily all of our elected members would have been in care homes or hospitals, given the fact that we had restrictions.
Sure. Now, paragraph 2.27 of your statement, you say that, quote, COSLA's role is to represent the views of its member councils and to ensure that any strategic decisions that are capable of being operationalised by local authorities were. Were you aware of any barriers to operationalising guidance put out by the Scottish Government in March 2020, which noted that facilities would be advised of IPC measures when hospital patients were discharged to care settings without testing?
No.
Or not? And again, I think to round off this subject, this topic, I think you probably covered this already, but just for clarity, is it your evidence that all care homes did have appropriate isolation facilities and sufficient resources, beds, PPE, staffing, to have undertaken a precautionary approach in every instance of hospital discharges prior to May of 2020?
I think the guidance that was drafted with support from professionals who were working in the system. Can I say that every single care home in Scotland was in that position to apply that? No, I can't.
Yeah.
What I can say is that the guidance was drafted with those who could say to a degree certainty in terms of representatives of the workforce from across the sectors.
Yeah, that wasn't quite the point. Did they have the appropriate isolation facilities and sufficient resources to carry through on that guidance and in terms of taking a precautionary approach?
As far as I'm aware, but that would be for the care inspectorate potentially.
In terms of visitation, paragraph 4.2, you state that, quote, COSLA officers had to remind officials and clinicians that care homes are not purely clinical settings, but the homes of the residents, ensuring that they continued to feel like that, even in the midst of lockdowns, was of vital importance to the overall well-being of the residents, unquote. Firstly, do you agree that relatives being able to visit their loved ones is an example of this, what you say, the vital importance to the overall well-being of the residents?
Yes.
And secondly, the inquiry has heard evidence that visiting policies were inconsistently applied between care homes. Was that an issue in Scotland, so far as you're aware?
So again, I think if you look at the minutes of the meetings that were taking place, I think that was raised in terms of different care homes applying different visiting restrictions. Some of that was later on in the pandemic where we had different tiers though as well. So it's important to tie it to the right timeline.
Yeah, thank you. Now, Kevin Mitchell from the Care Inspectorate has told the inquiry in his witness statement that you were briefly referred to earlier, and just for the record, it's paragraph 295 of that statement, that guidance issued on the 26th of March of 2020 suspending routine visits in care homes, quote, did not achieve the correct balance of managing risks with the rights of individuals and did not sufficiently consider the unintended consequences of the visiting restrictions, unquote. Were you and COSLA aware of those concerns from the Inspectorate?
Yes.
And did COSLA respond to that guidance or raise those concerns with the Scottish Government?
So again, I think if you go back and look at the minutes, we were having those ongoing conversations in terms of the balance between the two things.
Yeah, so you raised those concerns. What was the outcome of raising those concerns with the Scottish Government?
So I think the outcomes took a bit longer than we would have expected to see, but we were absolutely clear as we came out of the first lockdown that visiting restrictions needed to be one of the first areas that we looked at.
Thank you very much.
Thank you, Mr Weatherby. Mr Straw. Mr Straw is over there.
Good afternoon. I represent John's Campaign, the Patients Association and Care Rights UK. You say at paragraph 4.24 of your witness statement that the Scottish Government's emphasis was on stopping the spread of the virus. And you also say in your statement that COSLA is fully supportive of the proposed ANS law, which will ensure that in the future there will be a different approach as to how restrictions on visits will be managed in care settings. You appear from this to consider that the government focused too narrowly on infection control and neglected to properly consider and address indirect harms. Is that correct?
I think the four harms Scotland approached the pandemic was useful. I think in terms of visiting restrictions, it's an area where we perhaps allowed the infection prevention control to be given a higher weighting than potentially the outcomes for people.
And do you know why that balance wasn't correctly struck and what can be done to ensure that it is correctly struck in future?
I think the difficulty we had was anecdotally we knew what it was going to mean, at least not because my own grandmother was in a similar situation, but we didn't have the evidence necessarily about how visitors were or were not transferring the virus in care homes. So there's something for me about us understanding that as we move forward, because if we're going to implement Anne's Law in Scotland, which we are, we need to understand what are the practical ways in which we can make visiting during a pandemic or any other outbreak safe.
So is this right? Getting better data and information on both the indirect harms of restrictions and then also understanding how they can be managed?
Yes.
Thank you. A different topic. In your statement, you mention a range of engagement that COSLA undertook, but none of the organisations that you actually mention in your statement include people living in care homes and their chosen supporters. Could or should COSLA have done more to listen to and learn from lived experience from people like that?
So I think COSLA as a membership organisation working at a national level, we're probably one stage removed, but what we were doing was taking regular feedback from our 1,200 elected members who live and work in the communities that they represent, our professionals who were working in those systems, and indeed speaking daily with people who had lived and living experience. So I think at a national level it's something that COSLA have reflected on and will continue to reflect on, but we were absolutely taking feedback from our member councils on what they were picking up from the ground and therefore from relatives and residents of care homes.
Okay, so you consider that was an important thing to do and you haven't made it?
Absolutely.
Okay, thank you very much. Thank you.
Thank you, Mr. Straw. That completes the questions we have for you, Ms. Dickey. Thank you very much for your help for the second time. I haven't checked. I'm not sure whether I can say that's it. But if it is it, thank you so much for all the help you've provided to date. Very grateful. And thank you for travelling down to see us.
Thank you.
Very well. I shall return at 22.
All rise.
His hands.
My lady, good afternoon. If I may call Ms Nadra Ahmed.
I swear by Allah
I swear by Allah
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
whole truth,
the whole truth,
nothing but the truth.
and nothing but the truth.
Thank you.
Ms. Ahmed, I'm sorry you've been kept waiting. I hope you haven't, but you're our last witness of the day. That's why.
It's all
If
right.
that's a privilege or a disaster.
Thank you. Ms Ahmed, good afternoon. You are here today as the Executive Co-Chair of the National Care Association, or NCA for short, to tell the inquiry about your members' experiences during the pandemic. And you have produced a statement, which for those following is at INQ 000515683.
I have.
Thank you. And just starting with some of the work of the NCA, is it right that it represents and supports small and medium-sized care providers in England and has
Yes.
approximately 1,000 members?
Yes.
The majority of your membership are nursing or residential homes,
Yes, it is.
and the remainder are home care, but essentially 92% are care and residential homes.
Yes, and learning disability services.
Thank you. You have told the inquiry that smaller care homes have around 20 to 40 beds and medium-sized providers have 50 to 150 beds. Is that right? And is that in England?
Yes, it is.
You have described the pivotal contribution of the SME sector, as you refer to it, in your statement, and how it is the backbone of care provision. Can you briefly explain why it is so important?
Yes, thank you. We use that quite a lot because over 80, I think it's 83.4% of the sector is made up of small to medium-sized care providers across the country, and they are set in all sorts of different areas, so accessible through most communities, and that's how they are located. But they're also owned primarily either individually or with small boards, so there's not private equity in the people that we work with. It is investments that are made by the providers themselves.
And you have told the inquiry that during the pandemic you had almost daily contact with civil servants about issues in the care sector. We're going to come on to more detailed of those issues, but what were some of the issues that you raised?
I think it was primarily because information was so slow and actually very, very inconsistent. So as from the perspective of how we were going to handle it, because initially when the pandemic was talked about, there was late February, we were still kind of talking about Brexit, and we were talking about the challenges for the sector from that perspective. And that included shortages of staffing. And so we were very concerned when the pandemic was kind of announced as being there. We were told that it wouldn't have an impact on our bit of the sector initially. There was very little information coming. There was a little bit of a panic amongst our members, because we have things like neurovirus that are around. We have all those kinds of issues that come into our settings, and we've always managed through infection prevention control mechanisms to keep our residents safe. But of course, the pictures that were coming out from across Europe were quite challenging, and the smaller providers, for example, there was something that came across with a care home in Spain, and all those issues, they were causing people quite deep concerns. And as small providers, what we have to remember is they are it. There isn't an HR department, there isn't anyone else there from a regional office, generally speaking, able to deal with the challenges that they were facing. So we started to get a slow trickle of concerns that were coming through to our membership. So we were pointing it out on a regular basis, asking for information, mostly about the virus, mostly about what the symptoms might be, what people needed to be looking out for, all of those kinds of things.
And did you get that information when you asked for it?
I think initially it was really quite. It was downplayed that this was not something that was going to impact on our piece of the sector, and we didn't need to worry about it. We needed to support the NHS. That was primarily what we kept being told. I think families were beginning to see some challenges as well. We didn't really get. I guess the shortest answer is no, we didn't get what we were looking for. We were given explanations that actually were not consistent.
And is that at the start of the pandemic?
Yes.
Did it improve?
It started to improve with more regular meetings.
Can you remember when that was?
It was probably the second week of March or so, sort of 13, 14, 15, something like that, that we suddenly started to get a lot of meetings appearing in our diaries from departmental colleagues and a little bit from. We had very little contact as in National Care Association. We've never been seen as the organisation that kind of really needed to be talking to the NHS, for example. Very little contact with the NHS except at local levels where our members did that. Suddenly we were beginning to get that sort of linkage. So we were trying to work quite dynamically with the kind of messages that were coming through. I think that the issue was there was quite generic information that was really much more suited to larger establishments because it was coming down from the NHS kind of perspective. Smaller providers where you've only got 10 residents, or you might only have 20, or you've got a learning disability service with 4 or 5, there was no tailoring towards that messaging.
Did you have the opportunity at those meetings, or perhaps in email correspondence outside of the meetings, to provide any feedback on the guidance or decisions that were being made to represent the views of the providers that you represent?
Yes, we did. And we worked with colleagues in the sector who are also representatives, and we worked really hard to try and make sure that our views were being reflected, and we were getting real intelligence from people on the ground. You know, when somebody rings you up and says, you know, I've just taken somebody back from the hospital, and now we've got five of our residents are poorly. You know, what do we do? How do we deal with this? People were kind of doing this. It was a fast-moving scenario. So by the time you actually went back to a meeting to talk about the challenges, the provider would already have to have made some decisions. And I think there was a lot of clash on the way that we were being told to look at things. I think one of the problems that was really clear to me was that there were people who were being asked to write guidance, to talk about these things, who had no experience of either the social care sector or certainly not smaller providers. So they were quite new into these roles. They were being brought in. They were having to do quite a lot of research. And I think picking up so many different messages for them was difficult. But for us, on the ground, for our members, it was becoming quite impossible, because we also had a workforce that was really worried. You know, what we have to remember is our workforce were the ones that were on the ground. They didn't have any kind of support except us trying to support our members.
And I'm going to come on to ask you about that, but two things, please, if I may, on what you've just said. The first is around the staff structures within the smaller providers. And I think you've said in your statement that the lack of administrative staff in some of those care providers made it more difficult to implement and communicate changes in guidance in a timely manner. So what support do you think could have been provided to them to have helped with that?
Well, I think by that, I think plain English would have been really good as well. You know, just being able to pass things through in a timely manner. You know, for our administrative staff who were used to dealing with rostering and residents and, you know, making sure the files were right, to suddenly have to deal with quite medical terms, you know, quick implementation methodology. I think it was really beginning to... I think it was challenging because their roles were changing so quickly as well.
Okay. And is it right that you set up a WhatsApp group, or the NCA board set up a WhatsApp group for managers and owners to help with interpretation and dissemination of information and guidance?
Yes, one of our colleagues on the board, who is a nurse herself, Anita Astle, she set up the WhatsApp group. And very quickly it picked up momentum, and we had people. It wasn't just NCA members; it was just everybody was joining it. It was the only mode at that point that was immediate. So everything we were doing at the national level and talking to colleagues in the department or indeed in the NHS, it took time because it had to be signed off, you know, and sometimes that would take a long time. We'd get all sorts of things coming through which contradicted each other. Sign-offs were taking a long time, but that particular WhatsApp group suddenly got momentum, and it also had doctors on it that would come on and give geriatricians who were actually giving really good advice as well. So they were able to, so a lot of them were care home providers or staff, but there were also people that were happy to do some of the research behind some of the guidance to try and interpret it into simple English, into plain English, and get it back.
I'd like to just ask you now about the hospital discharge policy that was introduced in March 2020, in which care homes were asked to take patients that were in hospital. To your knowledge, what were some of the practical difficulties for small and medium care providers in following the discharge requirements, for example, around isolation or cohorting of staff?
I think the difficulty, there were various issues around this, because obviously by then there was more concern. People weren't very keen on taking people out of hospital, but I think we were being vilified by everybody if we didn't take them. And some providers chose not to take them and kept the virus out of their services. But those that did, to try and support the NHS, because that was the mantra, were then having to look at the way that they were isolating. So initially you could isolate in a room, and the other residents were able to kind of go mingle. And then, very quickly that began to change, because the more people that were becoming infected, you'd have to cohort them, create zones where only certain people worked. So that it had an implication on the staffing as well, because you'd have the people who were working in a red zone and, all of those things. But the other challenge for our providers, the SME providers, were, we had converted buildings, and those converted buildings created challenges, narrow corridors potentially, room access being very different to a purpose-built building. So providers and their workforce were doing the very best they could quite quickly to accommodate people who had come out of hospital. We were told that they didn't need to be tested initially. They could just be discharged, because if they didn't show symptoms, they didn't need to be tested, which was, it was a bit crazy at the time, because of course, if they were, and we have examples where a provider who has only 20 beds had to get somebody, had somebody come back from the hospital, and they brought COVID with them, and within 3 or 4 days, he messaged me to say that 15 of his residents now had COVID. He didn't know how to deal with it. Half of his staff were now isolating, and he was in a really, really challenging position. And so we were trying to pick up these messages and see what we could do. There was no local authority support that was coming through. There was nothing that was actually, there was nothing present in mind or in soul or in word that made us feel that we were being looked at or supported. So, that particular individual, he phoned me. The last time that he phoned me was about 11 o'clock one night, because he was on his own in the home trying to deal with COVID positive patients. So it was really challenging. To try, what do you say to somebody at that time of night? How do we kind of translate some of this really late stuff that was coming through to us to say, it'll be fine, you'll be fine? How are we going to translate that into helping that individual?
And you attended meetings later in 2020 regarding the development of designated settings. That's alternative accommodation, facilitated by local authorities to receive discharge from hospital if the patients can be isolated in the care home. You raised some concerns at those meetings about the policy. So I want to ask you whether overall the NCA supported the development of designated settings.
I think we were concerned. I think it was something that was evolving, and providers were willing to provide it. So that's the position statement, if you like. If providers were willing to provide it because it would support the NHS at the time, I think our concerns were very much as to how it was going to be managed. This wasn't something a smaller provider could have done. This was going to be something that had to be invested in a very different way. Where were the staff going to come from? Because we were already having challenges around staffing. And I think for me, there was an issue about putting everybody who's COVID positive and the mental health of those individuals that were getting better and, being transferred into a service. I wasn't sure about the well-being side of it for those people as well. Did I support it? I think I supported it because it was a potential solution to a very, very chaotic period. I was extremely concerned about the insurance implications for people. I was worried about families and how they would feel if loved ones were being transferred into a COVID positive environment, and how that visiting might, how that might impact on them. So my honest answer is I wasn't sure about it, but I think in the position that we were in, it was a solution. And initially there was a lot of interest in it, but I'm not sure how many people eventually did take the option to open them.
Okay. Moving on then to the suspension of routine inspections by the CQC. So a letter was written by the CQC in the middle of March 2020, which your organisation were invited to consider and to look at with, I think, 1 day's notice. In your feedback, you asked whether care providers needed to notify the CQC of COVID-19 deaths, and the response from them was that they would come back to the sector shortly. Can you recall why the NCA was asking that in particular?
Because we are required to give notifications of death when that occurs in a service. And of course, providers, by the very nature of the role that they do and the way that they're regulated, do not want to fall out of regulation with the CQC. And there seemed to be this kind of, CQC went AWOL. There was no support for the sector. They were basically shutting down, although they were telling us that they would be around. Calling them became quite an issue. So how are we going to deal with this? Because we knew that in certain environments there would be more deaths. How did they want to be notified of them? The timely way in the way, because these are all things that were happening. You could have 2 deaths in a day. You've got to sit down. You've got to be dealing with other people who might be COVID positive. We needed we needed more clarity. I think CQC was very remiss in that they just shut the doors and decided that's how they were going to implement it.
So it wasn't until the 9th of April that providers were informed that when making a notification, they should use a revised form to notify the CQC if the death of an individual was as a result of confirmed or suspected COVID-19. So do you think that was introduced soon enough or confirmed soon enough?
No, I don't think so, because it was really difficult. We also, we must remember that GPs had stopped coming to care homes as well. We were in a state where confirming death had become an issue as well. All of those things, I think it should have been done quite quickly because the deaths had already started. So a month later is a long time for a provider to be wondering how they were going to, make sure that they were doing the right thing and they were staying within their regulatory responsibilities.
And I think in your feedback in the middle of March, you actually asked that any information the CQC provides is unambiguous and provides clarity to avoid adding to mixed messaging. So did the messaging from the CQC do that?
To a degree, I think we were being stronger by then to make sure that we were making the rules in a way that was going to suit the providers. And I think, for example, when you're getting something from CQC that's saying you must close your doors, and then you're getting something that you must enable visiting, all of those kinds of things. We needed much more clarity about how and where we sat. I think we were really trying hard to get CQC to work with us in a way that would support the smaller providers with limited admin support. What we got were ambiguous answers, which really didn't make it any easier for us to be clear that we were doing the right thing.
Did that improve as the pandemic progressed?
I think it improved slightly. It did improve slightly, but there was always a massive pushback to us, whenever we asked questions about something. I think one provider actually sent me a note saying he'd notified his CQC inspector about something or other and said, how do you think I should deal with this? And the note he got back was, well, you're the professional. You should know how to deal with it, which really, so I guess the best way to answer this is the challenges were that we had inconsistent inspectors giving responses. So the responses were not, they were not consistent in different areas. So if you've got homes in 2 or 3 areas, you would get 2 or 3 different answers.
Moving on now to a slightly different topic, and that's around the implementation of IPC measures. What issues or barriers, if any, did you hear from some of the providers that they were having around implementing IPC measures, particularly perhaps those providers that care for people with dementia or learning disabilities?
I think the challenge is, what we have to remember is that we as a sector, we deal with infection prevention control as a norm. There is training for our staff. This was a completely different thing. This was a completely different beast that we were trying to come to terms with. So it was becoming very evident that we needed more, hand gels, gloves. We have gloves and aprons and things in our services, but then, of course, the mask thing was coming in. One of the difficulties around the mask, and we had long conversations about this, is if you've got somebody with dementia and you've got members of staff wearing masks, how do we make sure that we can safely be talking to them, helping them understand things, all of those things, because that's quite challenging. But of course, from our workforce perspective, we needed to keep them safe as well. Dementia was really difficult because people didn't understand why we were walking around in that kind of way as well. Trying to keep people calm about, about the methodology that every home was having to adopt in its own way. If you were cohorting people with dementia, what did the impact on them? How do you keep them safe in a particular area? We know lots of providers were putting up those kind of baby gates almost so that people didn't venture forth, and or trying to keep everybody safe in the environment they were in. I think staff found it quite difficult because when they were talking, masks were a premium anyway. That created quite a lot of challenge because, and we talked about transparent masks. The trouble was, if I'm absolutely honest, there was a huge amount of talk. When it came to the action, we had to actually take our best guess at what we could do to make sure that we could keep the 20, 30, 40, 50 people that were in our care in the best way that we could. So there were lots of conversations.
And in fact, you did raise the issue of the need for training on infection prevention control with the Department of Health and Social Care very early in March, an email correspondence. So in your view, was there sufficient training on IPC, either at the start of the pandemic for staff, or did it develop later on?
No, there wasn't. There was no resource put into it, and it was quite piecemeal.
And on a slightly different topic, but still around IPC, is testing. You were involved in attending meetings alongside the Local Government Association and ADAS around kind of September 2020, where testing was discussed. And one of the issues that arose in early September was that just under 400 homes had not yet done any testing. So what were your members' experiences around accessing testing, and why do you think perhaps they weren't testing?
Access to testing came very, very late for our bit of the sector. We had deliveries were delayed, really badly delayed to small and medium-sized providers. We were getting regular emails from providers who were telling us that they had not received anything. I think they felt quite isolated. They felt like they had been forgotten. There were some very angry emails, very long emails from people who were desperate. From the very outset, as soon as we heard about testing, we knew it was one of the ways that we might be able to support people and keep more and more people safe. But we were very much an afterthought. You know, we know that it was all about keeping the NHS safe, but it was our workforce that was on the ground. It was, you know, we were the ones doing that sort of caring responsibility for one of the most vulnerable groups. So the 400, you know, I've got no specific idea of why they didn't, but every provider that contacted our offices was just desperate for tests. We also had some tests that were not working. They were giving wrong readings. We had tests that when they were sent back didn't arrive in a timely manner, and we were told that they weren't right. So the whole testing scenario, until quite late on, until later on into October, November time, when we started to really get what we needed. The initial stages, people were desperate. You know, providers wanted to be the test sites for it. So we were finding that we knew that this was the way that we needed to work to get people tested. It also had implications for for the home itself, obviously, because there was a routine and there was a regime that had to be put in. But we were certainly not prioritised.
I'd like to ask you now about one of the recommendations, in fact, in your statement, and that is for there to be clear guidelines and protocols for care providers to minimise staff movement. So can you describe for us what the experience was for providers of staff movement or restrictions on staff movement during the pandemic?
Well, we were short-staffed, of course, and we were working under quite very difficult circumstances. We had staff that were living in homes, in gardens, in tents. You know, we had staff that were were actually keeping away from their own loved ones in order to keep the people that they looked after safe, and they weren't going home. So we had all of that. What we also, you know, the use of agency staff became very difficult because we couldn't be very clear about having agencies coming into our services. Everybody was trying to create a bubble so that we didn't create the challenges. Movement of staff was by that, I'm assuming what you're meaning is them going from one home to another.
Yes, indeed, yeah.
Yes, so that there was always a risk attached to that, and so that would be something that you wouldn't do unless you were absolutely desperate. But most providers did not want to be doing that either. They were trying to create, you know, it was creating bubbles. Home care, you know, we had, again, the guidance was really difficult. There were some people who were sharing cars, and we were being told that, you had to sit in the back seat and the front. You can't keep changing the rules. You either do it or don't. If you're sitting in a car and there is infection there, then surely that infection will spread if you're sitting in a car. It just didn't make sense. So movement was always an issue. We were trying to make sure that people understood to limit it and not have people going into too many different services.
And it's been suggested to the inquiry that one potential way to achieve that in future would be for a care home to take a fewer number of staff, but who are employed to work full time, or that the worker could continue on a 0 hours contract and take up another job if they didn't have any hours from that care home. Do you think that would be practical for the providers that you represent?
I think that's a really strange, it's a very strange suggestion. We have to remember that the workforce chooses how they work and where they work. We can't just make assumptions that they'll be happy to do what we want them to do. The duty of a care provider is to try and keep their home fully staffed in order to meet the needs of the people that they support. And so to try and tinker around the edges with how you might get it round in a different way I honestly don't know how to answer that question. For example, 0 hour contracts, some of our workforce choose to go on 0 hour contracts because it suits their work-life balance. I'm not sure a methodology like the one you've described kind of sits with me as being a solution.
Just briefly, in terms of PPE, which you've touched on already, how practical would it be for small and medium care providers to have, say, a month's worth of emergency supply of PPE? And would that be helpful in a future pandemic, do you think?
I think access to PPE has to be one of the recommendations if we came to something like this again. With the stock, I've thought about this quite a lot because I think one of the challenges we faced when we were given a drop of PPE was that it was out of date. That the care providers were sent PPE that was out of date. And we had providers sending us pictures of this. I think there has to be a stock. I think what we have to be really, really clear about is that social care looks after some of the most vulnerable people. And it has to be treated as a priority, not as a secondary. It has to be moved in a way that the public and those that are making decisions understand the importance of us having access to resource, for us to be funded appropriately in order to make sure that we have that resource when we need it. And we need it in a timely manner. We don't need it 3 weeks down the road when somebody suddenly thinks, oh, actually, it is going to affect the social care sector. Better do something about it. Doesn't work.
Forgive my interrupting. I think the point of Ms Hand's question was an answer from Mr Hancock, which was that the care homes should have, I think he put it as a cupboard, in which they could store a month's worth of PPE. In other words, it wasn't getting access to the emergency stockpile or supplies. It was having a month's supply in a cupboard.
Well, most providers would have a reasonable amount of... Thank you for clarifying that for me. Most homes would have a supply because that's what you do. You have a month or 6 weeks supply, just in case something goes wrong. We didn't have that supply of masks, though. So, this was a new way of doing it. So, actually, in answer to Mr Hancock on his point, had we known that we might be hitting something like that, I think providers would have done that, but they did have sufficient for their daily use. And had the government not told us not to worry about it, we may have been a slightly different situation, because accessing that PPE became an enormous challenge for us straight away, especially when we started to hear from our suppliers that they could no longer supply to the social care sector because it was being rerouted to the NHS. So if we, how much would have been rerouted if it was due to come to us for a stockpile? I think those things are the reality that was on the ground, and and we ought to speak the truth about it. We ought to be telling the truth about this, that PPE was diverted away from the social care sector in the early stages to go to the NHS, and that is a fact.
Ms Armitage, you mentioned in your previous answer funding, so if I may just ask you briefly about that. You have included in your statement some evidence from a survey that you conducted with your providers around whether they'd had access or been able to access the government funding that was that had been made available. Could you briefly just describe some of their experiences of accessing the government funding?
I think it wasn't the easiest methodology, but actually, I have to say that it was the only bit of money that came to the front line and was really helpful to the sector. So from that perspective, we're grateful for that. But it wasn't an easy. It was routed through local authorities. We understand that. I think it was 30% from memory from the survey of people who said they didn't get it, and it was held back, which is quite worrying. Why it was so inconsistently distributed. So certain local authorities didn't distribute it in the way that they did. Others did really well, and I think that inconsistency, God forbid we have anything like this in the future, must be ironed out. It has to be. If it's ring-fenced, it needs to come to our sector.
You have also provided some examples of the types of additional costs that were incurred by providers, such as reconfiguration of care settings, buildings, specialised equipment and increased staffing costs as well. Were small and medium providers disproportionately affected by that?
I believe so. I think we were having to, the adaptability of our services were quite challenging. Our insurance costs went up, I don't know, tenfold. So people tell me 100-fold. Insurance companies weren't willing to insure our services because they wouldn't do the COVID. So reinsurance became really difficult. That hit us quite quickly, and providers were paying. I think one of the examples I remember was somebody who had paid £1,800 for their insurance the previous year were being asked for 8,000-9,000, and then the following year it went to about 20,000 or 30,000. So that was an enormous cost. Food costs were affecting us as well. Of course, the delivery chain impacted on us as well. There were the reconfiguration, for example, putting up pods and things that all came in for the visiting. People were already starting to look at window visits, putting up perspex in between. So all these were additional costs that we weren't supported with.
And at the end of your statement, you have provided a very helpful list of recommendations, which the inquiry will publish in full. But I'd like to ask you about one of those, if I may, and that's that the NCA would support a database of all adult social services, including those that are not registered with the CQC. Is that right?
Yes.
And in regards to that register, would that also include social care workers?
Yes.
And do you have a view as to who would be best placed to collect that data?
I don't have a view on that, not a strong view, no. I think there are various people, various bodies out there who could do the job.
And do you have a view as to whether it should be mandatory or a choice, voluntary?
I think that's a much more difficult question. I think thinking back to mandatory vaccinations, I wouldn't want to lose 40,000 staff because of something that we were mandating, which wasn't mandated anywhere else. I think if we showed the benefits of it being a useful collection of data, and then people move towards it, that might be a better way. I don't like, since the mandatory vaccination scenario and the fiasco that was, with social care being deliberately targeted to have that inflicted on them, and the loss of a very good workforce that we had, who were never going to come back because they could go into the NHS and they could work there and not be vaccinated. Why would they come back to social care where that other mandatory things could be thrown at them?
And just finally, how do you think that would help in a future pandemic if there were such a register?
Well, I think we'd know where people were and how we could access the data could be used in so many different ways of making sure that some of the things that happened didn't happen again. I think having that, I mean, data collection has become a big thing. It's great to collect data, but it's how you use it that makes the difference. And if we have it, then we must have a methodology that goes with it as to how we prevent the challenges that we faced at that point.
Ms Ahmed, thank you. My lady, those are my questions.
Thank you very much, Ms Hans. Mr Weatherby. Mr Weatherby's just there. Just a few more questions.
Thank you very much, and good afternoon, Ms Ahmed. I ask questions on behalf of the COVID Brief Families for Justice UK group. Continuing with the theme of data, in terms of data and ethnicity, the Public Health England report Beyond the Data, published in June of 2020, noted that there was only one study which reported mortality in healthcare workers in the UK by ethnicity, and that further analysis was urgently needed to understand the morbidity and mortality of health and social care workers due to COVID, with a particular focus on BAME groups. Was there, in your experience, a general lack of recording of the ethnicity of not only healthcare but also social care workers at the start of the pandemic?
Well, it was never mentioned. It never figured. It never factored in any discussions or debates that we were having in any meaningful way. I think it became much more apparent when the mandatory vaccination thing came into place, because there was a lot of concern that a lot of people from ethnic backgrounds were not willing to take. And that was the first time that data was starting to be produced about how COVID would impact people from ethnicity more.
In terms of the further analysis recommended by PHE, did the NCA involve itself with that?
We've always, yes, we did.
Yeah.
Yeah.
The PHE report recommended the routine collection and recording of ethnicity data as part of routine NHS and social care data collection systems, and the sharing of the data across local health and care partners to inform and mitigate the impact of COVID-19 on BAME communities. And do you know if that recommendation was actually carried through?
No, I don't.
Would you have supported that recommendation at the time or going forward?
I think I would have. I'm always concerned about, again, I repeat what I just said. Data collection is important, but it's why it's used.
It's what you use it for.
And that's where you've got to be very clear and careful that data is not misused.
Yes. Finally, in terms of PPE, the inquiry has heard evidence in previous modules of healthcare workers from ethnic minority backgrounds not having culturally competent PPE, particularly at the start in the first wave. Was this, to your knowledge, addressed across the care sector?
No.
Thank you very much. That's all I ask.
Thank you, Mr Weatherby. And then I think Mr Straw, who's over there.
Good afternoon. I act on behalf of John's Campaign, the Patients Association and Care Rights UK. At paragraph 72 of your witness statement, you state that the consultations and guidance regarding the reintroduction of visits by loved ones were consistently behind the reality on the ground. Is one reason for this that there was no mechanism which ensured that organisations who represent social care users and their carers were speedily consulted for changes to the guidance?
I'm kind of missing a few words that you said there, sorry, at the end. Was the consultation?
Was the reason why that guidance didn't reflect the reality on the ground that speedy consultation didn't happen with organisations who represent care users and also carers?
I think the visitation consultations were very haphazard, and certain parts of the sector were potentially talking to interested parties, and certain bits of the sector weren't. What was very evident for us was that some of that was contradicting each other. Some of the some of the recommendations were challenging each other. And one of the things that kind of is really important, I think, in all of this is that we were concerned that providers, certainly my members, the SME part of the sector, were trying their best to try and facilitate visiting for people, because we could see the difference it makes. Suddenly, you've got the staff are being all things to everybody, and so the pressure on our staff group was also great, but being able to have people coming was seen as a benefit. It was seen as a benefit, but then some of the consultations put barriers in the way. There was such negativity around it in some cases. So I think it wasn't, I don't think the consultation was carried out to the best, in the best way that it could have been.
Okay, thank you. Then coming on to visiting, and you've just touched on it, some of the benefits of visiting. Do you consider that the visiting restrictions struck the right balance? And I'm particularly interested in the exclusion of essential carers, family carers for people who had significant care needs, like dementia sufferers. Did those visiting restrictions strike the right balance in your view?
I'm sorry, as you taper off, I didn't hear the final bit.
Did the visiting restrictions strike the right balance? So, for example, with essential carers not being allowed to care for their loved ones when they had experience of doing so at home?
Well, I think it would have always been beneficial for people to be able to visit their loved ones had they been caring for them at home. It was a risk to their own health that was causing the issues for people. But actually, we had a lot of the smaller providers were telling us they were being told that they were in breach because they were allowing people to come in tested. By the time the testing had come in, I do believe that if somebody has been caring for somebody in their own homes and they then find them in a care setting, that they should be enabled, if God forbid this all happens again, they should be enabled to be able to support their loved one.
This may be obvious, but you touched earlier on the importance for staff of care, a family or other carers being allowed in. It takes the burden off staff. I think you're also pointing there to the benefit for the individual themselves if they have that essential or family carer support. Are those two of the reasons why it's important to have access to essential carers?
Yes, I mean, I lived through it. My father was in a care home. He was there, and I remember the visits to him. I remember the visits when he was at home and trying to get food through the door for him, and then going into the care home and not being able to go in to see him. So, absolutely, I think it is. it's quite difficult to argue against taking the pressure off some of the workforce as well, but also enabling people who are willing and able. And one of the things that I think it'd be prudent to mention is that some of the people who initially were coming to visit in care homes, their loved ones were of an age that was considered to be at risk, and so they had to be, so the rules were that they needed to isolate or whatever, and it did have it has a detrimental impact on the person. I know what my dad felt like, because he would stand at the window and keep shouting to me to come up because he couldn't understand why I couldn't come up. So those are the challenges that we were facing. But absolutely, we've got to get it right. We've got to get it right if this happens again, and people benefit from seeing their loved ones. I don't know whether that fully answers your question. I'm kind of probably repeating myself.
It does. Thank you very much. And I'll move on to the final topic, and I'll try and speak directly into the microphone in the hope that helps.
I'm sorry, I'm also hard of hearing, so but I have got hearing aids in, but it's not picking it up, so it's partially my fault.
I'm going to shout. Earlier you mentioned innovation. Earlier today in your evidence and also in your statement, you mentioned innovations such as visiting pods to facilitate visits. Were you aware that these pods were considered to have major disadvantages for some people, people with cognitive, hearing or visual impairment, such as dementia, and people considered that they didn't enable carers to provide care in an effective way?
I wasn't aware of that. I wasn't aware that the pods were considered to be not a good way of facilitating visiting, no. It was something that was certainly used quite a lot throughout the sector, especially in SMEs where space was limited. It was creating additional space so that people could also not have to come in through the building. They were going from outside in order to make that happen. And I wasn't aware of the study that you've just spoken of.
Just one broader and final question then. Would you agree that face-to-face or in-person care is really important for certain types of people needing care, particularly people with dementia?
Absolutely.
Okay, thank you very much.
Thank you, Mr. Straw. That completes the questions we have for you, Ms. Abbott. I'm really grateful to you. I appreciate how distressing it must be for a lot of witnesses who have to think back through those really difficult times, and I'm sure that all the people you represent had a really tough time, as did their residents and their loved ones. So thank you very much for your help, and I'm sure there'll be some support for you when you leave the hearing room.
Thank you, my lady, for
Thank
the opportunity.
I shall return 10 o'clock tomorrow.
Thank you, my lady.